Hello Medicos, good day to all of you. This is Dr. BK for you, and today I am going to discuss about the rectus sheath. So our learning objectives for today regarding the rectus sheath would be, so what is actually the rectus sheath and why it is present, what are its functions, its extension, borders, then what are the contents of the rectus sheath, how the construction differs at various layers or levels. Okay, so you can call it as a construction or the formation of the rectus sheath at the various levels. Then followed by it, after the contents, discussing the contents, then we will actually conclude this chapter with the applied aspects of the rectus sheath. Now, what is a rectus sheath? So we all would have actually known about the sheath, facial sheath. The fascia actually forms a sheath around the muscles. Now, this is also a sheath which is covering the muscle, that is the rectus abdominis muscle. So you are able to see here a muscle, that is the rectus abdominis. It is seen in the midline, on the either side of the midline in the anterior abdominal wall. It is vertically disposed, that is why it is called as rectus. Recti means straight. Okay. Now this muscle along with some other structures are actually enveloped inside a sheath. Now this sheath is actually not a facial sheath but an aponeurotic sheath. You know what is an aponeurosis? The aponeurosis is a flattening of the tendon of any muscle. So here also we have seen the three muscles of the anterior abdominal wall, the external oblique, then the internal oblique and the transverse abdominis. These three muscles, they form flat aponeurosis through which they are getting inserted extensively into the linea alba, then in the lower part pubic tubercle, pubic symphysis along the costal margin and iliac crest, inguinal ligament. It has got various places. So this aponeurosis is going to modify itself and cover this rectus abdominis muscle. We all know that there is no deep fascia in the anterior abdominal wall. So each muscle, whether it is the three layers of three muscles, they are not covered by a deep fascia. So, but the rectus muscle is actually covered by the deep fascia. And this deep fascia is in the form of a rectus sheath. Now, we will understand about this rectus sheath, why actually it is present, what are its functions. Now, the rectus abdominis muscle is present on either side. This is one muscle for the right side and this one muscle for the left side. So naturally they are individually covered by their own rectus sheath. As I told you, it envelops the rectus abdominis muscle, and one more small muscle you are able to see here, that is the pyramidalis muscle, and along with it inside the rectus sheath you have some vessels and the nerves. The main function, to put it in a brief, it acts as a retinaculum for the muscle. So again, what is the retinaculum? You all know that we have discussed about so much of retinaculum, the flexor and the extensor retinaculum in the upper limb. Then you have the flexor retinaculum, extensor retinaculum, peroneal retinaculum of the lower limb. So the function of all the retinaculum, wherever the retinaculum you see, it prevents the bowstringing of the tendons. The tendon should not slip out of its place or bend while actually it is contracting. So here also what happens is, it is actually preventing the bowstringing of the rectus abdominis muscle, because the rectus abdominis muscle during contraction it should not bowstring or bow out of its place. It is a very long muscle from above downwards extending, and it is more prone for bowstringing because inside the abdominal cavity you have all the abdominal contents, the gastrointestinal tract, its accessory glands and all those things, and it expands all those things we have discussed in the anterior abdominal wall. So because of that only the anterior abdominal wall is yielding absence of deep fascia. So during its expansion or various acts, this muscle should not get bowed out. So that is why the rectus sheath in the form of a retinacula, even though it cannot be considered as a true retinacula. Okay, true retinacula is actually a modification of the deep fascia which is thickly formed by the collagen fibers. Even though it is not a very true retinacula, but to some extent it envelops these muscles and prevents it from bowstringing. And if you look at the rectus sheath, it is not uniform throughout its length. Anywhere you take a rectus sheath, the layers differ. So mainly the rectus sheath is actually discussed at the 3 levels. What is the boundary of the rectus sheath from above downwards? So it extends above the costal margin, then below actually up to the pubic symphysis. Okay. So above the costal margin it extends on top of the xiphoid process, and from there what happens? It extends up till the pubic symphysis. Basically, it is formed by the splitting of the aponeurosis of the internal oblique muscle. The internal oblique muscle, during its insertion, the aponeurosis, when it reaches the lateral border of the rectus abdominis muscle, it actually splits into an anterior lamella and the posterior lamella. To simply describe, you can tell it splits to form the anterior wall of the rectus sheath and the posterior wall of the rectus sheath. So which muscle? Mainly the aponeurosis of the internal oblique muscle is responsible for forming the rectus sheath. Is it only this muscle alone is taking part in the formation? Then the answer is no. This is reinforced by in front by the other muscles and also behind the other muscles. Okay. But the principal structure, the main part is contributed by the internal oblique, the splitting of the aponeurosis of the internal oblique into an anterior lamella and the posterior lamella, and these are reinforced by in the front by naturally the external oblique aponeurosis, and behind by the transverse abdominis aponeurosis, and behind that what you have is the fascia transversalis. Okay. Now, so we have seen the upper or the superior extent and the inferior extent. Then it has got a medial margin. Then it has got a lateral margin. So these are the boundaries of the rectus sheath: medial margin, lateral margin, superior and inferior extent, and it has got an anterior wall and the posterior wall. The anterior wall and the posterior wall, the composition differs at various levels. Especially it is discussed at 3 levels, the composition differs. Now, if you look at the formation of the rectus sheath, I told you it is different at various levels, and it is discussed mainly at the 3 levels. Okay. Above the costal margin, the rectus sheath, how it is present above the costal margin, the anterior wall and the posterior wall, how it is formed above the costal margin. Then from the costal or below the costal margin to a level midway between the umbilicus and the pubic symphysis. Okay, midway between the umbilicus and pubic symphysis is represented by an arcuate line. You are able to see that is actually the arcuate line, which is seen on the posterior wall of the rectus sheath. So from the costal margin, below the costal margin to the arcuate line, again you have the rectus sheath slightly different, and this is actually the main part of the rectus sheath or the classical part of the rectus sheath. You can see it is evenly balanced and how it is distributed. Then the composition again differs below the arcuate line. Below the arcuate line, what happens is the composition of the rectus sheath differs. The main part of the rectus sheath, the classical part, is below the costal margin to the arcuate line. Okay, so it is the typical rectus sheath. That's what I told you. It's the classical rectus sheath, where you can see all the layers are contributing equally and evenly. Then the third is the below the arcuate line. So under the 3 levels, the rectus sheath composition is actually discussed because it varies at these 3 levels. So here you are able to see above the costal margin, it is only formed by the external oblique aponeurosis, the anterior wall. Posteriorly, there is no rectus sheath at all, and it is lying on top of these 5th, 6th and 7th costal cartilages. It is deficient. Then below the costal margin to the arcuate line, that is midway of umbilicus and the pubic symphysis, the anterior wall is mainly formed by the internal oblique aponeurosis, anterior lamellae. This internal oblique aponeurosis has split, and the anterior lamellae, and also above the anterior lamellae you have again the external oblique aponeurosis. Comparatively, the anterior wall is actually thick. Posterior wall, if you look, it is mainly formed by the posterior lamellae of internal oblique aponeurosis. Then you have the aponeurosis of transverse abdominis, and behind that we have the fascia transversalis. Okay, behind that we have the fascia transversalis. Below the arcuate line, it has become very thick, the anterior wall, because all these layers we have discussed: aponeurosis of external oblique, anterior lamella of internal oblique, posterior lamella of internal oblique, aponeurosis of transverse abdominis. All these 3 has come to the front. It's very thick, thickest you can call it as the anterior wall of the rectus sheath. Posterior wall is actually deficient, and it is only formed by the fascia transversalis. You cannot tell deficient, it is very thin and only formed by the fascia transversalis. Okay. So here you are able to see the abdominal wall, a very beautiful picture. So usually anatomy, what happens is pictures speak a lot than the text. So a beautiful picture, it should not only be a beautiful picture, so a correct and apt picture conveys exactly what needs to be described or conveyed rather than 1,000 words. So that is why here I would like to stress and also emphasize the importance of the diagrams, because today's students, they don't give importance to the diagrams and they are mainly concerned with only writing essays. Of course, in competitive exams, it is mainly you are going to deal with the objective answers, MCQs, but subjective part, essays or short notes, you have to draw diagrams. Now, leaving apart the examination point of view, for securing marks, definitely drawing diagrams are not. But if you draw and practice diagrams, then you can write answers on your own. You need not read the textbook or mug from the textbook. Okay? Your own diagram you can see and you explain what all is present in the diagram. That itself will be sufficient for you to score marks in the examination. Okay, so let us not deviate much from this session. So here you are able to see the anterior abdominal wall, which is mainly formed by the external oblique aponeurosis. Then you are able to see the internal oblique aponeurosis, and then you are able to see the transverse abdominis muscle. This is the rectus abdominis muscle in the midline, which is covered by the rectus sheath. Okay, and this in the midline, what you see is the linea alba. This is actually the linea alba. The anterior wall is mainly formed by the aponeurosis of external oblique muscle. Okay, and this is below the costal margin. This section you are able to see, and naturally slightly above the umbilicus, which means definitely it is above the arcuate line. So the typical rectus sheath you are able to see here. The internal oblique, the aponeurosis is splitting. You are able to see the aponeurosis here is actually splitting into an anterior lamina or lamellae and posterior lamellae. So anterior wall will be formed by aponeurosis of external oblique and aponeurosis of anterior lamellae of the internal oblique. Posterior wall will be formed by the posterior lamellae of internal oblique and aponeurosis of transverse abdominis muscle. Aponeurosis of transverse abdominis muscle. That is the classical part of the rectus sheath. This is posterior abdominal wall. You have the lumbar vertebra, anterior longitudinal ligament, and this is actually your psoas major and the quadratus lumborum muscles. Okay, this will be covered by your psoas fascia, and this quadratus lumborum will be covered by thoracolumbar fascia. That is the anterior layer of thoracolumbar fascia. So what happens, this anterior layer of thoracolumbar fascia only, laterally if you look, it will be continuous with the this fascia you see here behind the transverse abdominis, the fascia transversalis. Okay, the fascia transversalis. You could have, if you remember my external oblique aponeurosis, my anterior abdominal wall class, I would have described about the fascia transversalis. It is continuous with the anterior layer of thoracolumbar fascia, and in between, the more medially you come, it will merge with the renal fascia. Okay, so again, not deviating much from our rectus sheath class, I just want to describe, because when I saw this diagram, I just got carried out, and naturally you also try to just have an hold of it, so that again while discussing about the posterior abdominal wall, I will be again repeating these aspects. So the classical rectus sheath part you are actually able to see here. A very simple diagram to represent. So above the costal margin, it is formed only by the external oblique aponeurosis. Behind it is deficient and it is lying on top of the 5th, 6th and 7th costal cartilage. Then this is above the arcuate line, midway between the costal margin and the arcuate line. Anteriorly formed by external oblique aponeurosis. Anterior lamella, internal oblique at the lateral margin of the rectus abdominis is splitting into an anterior lamellae which forms the anterior wall of the rectus sheath. Then posterior lamellae and aponeurosis of transverse abdominis forming the posterior wall of the rectus sheath, along with the more posteriorly you see the transverse abdominis, the fascia transversalis. Now below the arcuate line, you are able to see all the aponeurosis has come anteriorly and the anterior wall is very thick. Aponeurosis of external oblique, both the lamina of the internal oblique and also the transverse abdominis. The posterior wall or the rectus abdominis muscle lies only on the transversalis fascia. Only 3 layers. The 4th layer they are given just above the pubis because the composition of the wall is the same as below the arcuate line. There is no difference between this level and this level. Only thing, one muscle actually you can see extra, that is the pyramidalis muscle. Apart from the rectus abdominis, you see a pyramidalis muscle in this level below the arcuate line. So only for that reason this 4th section has been given. Apart from that, the composition is same in the above last 2 sections. It's the same section at above the arcuate line. This is the classical part and this is below the arcuate line. External oblique aponeurosis, anterior lamella of internal oblique, posterior lamella of internal oblique, transverse abdominis, fascia transversalis. Below the arcuate line, aponeurosis of external oblique, both the lamina of internal oblique, aponeurosis of transverse abdominis all come anteriorly. Posteriorly, it is only the fascia transversalis which is forming the rectus sheath. Now, what is actually arcuate line? So, here you are able to see the arcuate line, the low free border of the posterior wall of the rectus sheath. You are able to see a thick margin at the arcuate line because beyond this the posterior wall is actually thin. It is only the fascia transversalis. Only above that you see the aponeurosis of transverse abdominis and the posterior lamina of internal oblique aponeurosis. This is actually your arcuate line and it is crossed in front by the inferior epigastric artery. Okay, inferior epigastric artery. So both these aponeurosis they pass anteriorly. You are able to see in a sagittal section this aponeurosis of the internal oblique, posterior lamella and transverse abdominis at the level of arcuate line. It crosses anteriorly and taking part in the formation of the anterior wall of the rectus sheath. So anterior wall is most thick here and the arcuate line is crossed in front by the inferior epigastric artery. So here you are able to see the inferior epigastric artery and this lower free margin, posterior free margin, lower posterior margin of the rectus sheath. Below that there is no aponeurosis, it is only the fascia transversalis. And that fascia transversalis is also thickened at this region and it is called as the iliopubic tract. That part of the fascia transversalis which is somewhat thicker and it is actually called as the iliopubic tract. So we have discussed about the composition of the rectus sheath, the anterior wall and the posterior wall at 3 levels. Next, coming to the medial margin, extending from above the costal margin to the pubic symphysis, it is mainly formed by the linea alba. I told you what is the linea alba. Linea means line, alba means wide. It is a tendinous raphe, fibrotendinous raphe, intersection of these aponeuroses in the anterior midline. Okay, these flat aponeuroses, what happens? There is an intersection of fibers. When there is an intersection of fibers, it is called as a raphe. You have muscular fibers, which forms a raphe. You have tendinous fibers, which also forms a raphe. So the extension of the linea alba is from the xiphoid process to the pubic symphysis. Below that, what happens is it splits into two layers, an anterior part and the posterior part. If you look at the linea alba also, below it is somewhat linear or thin, and above it expands or wide. Above the umbilicus it is somewhat wide, and below it is linear or thin. The superficial part of the rectus abdominis below continues as the fundiform ligament or the suspensory ligament of the penis. Okay. The lower part of the linea alba, the superficial fibers, they are continuous as the suspensory ligament of the penis, whereas the deep part forms the admenicum linea alba, which passes behind the rectus sheath to get inserted into the pubic crust. A triangular expansion which is actually getting inserted into the pubic crust. It is called as the admeniculum linea alba. So the medial margin is mainly formed by the linea alba. Okay, it is somewhat like a septum which separates the rectus abdominis muscle of both sides and also the rectus sheath. The lateral margin is mainly formed by the linea semilunaris, a curved line extending from the pubic tubercle to the only up till the tip of 9th costal cartilage. So beyond that, it does not extend above. This lateral margin is actually pierced by these thoracic nerves, the lower 6 thoracic nerves. They actually pierce the rectus sheath, and then they enter the rectus sheath crossing this line. Okay, so that is why what happens is any surgical incisions is not advised along the linea semilunaris, because you might actually sever or cut one of these nerves, which might lead to segmental paralysis of the rectus abdominis muscle. Okay, which might lead to segmental paralysis. So these lower 6 thoracic nerves, they pierce the rectus sheath, and then what happens? They supply the rectus abdominis muscle, and then afterwards they pierce the anterior wall of the rectus sheath and become cutaneous, and thereby, you know, the anterior abdominal wall, the dermatomes, the area of skin supplied by a single spinal nerve. So lower 6 nerves, okay, 7, 8, 9, 10, 11 and 12, they mainly supply. So the dermatomes mainly are also responsible for tracing out the referred pain, because they are from the spinal segments, and each spinal segment has got a grey and white rami communicants through which the sympathetic fibers also pass, preganglionic and postganglionic sympathetic fibers. Okay, through grey and white rami communicants. So through this sympathetic, the pain impulses are also transmitted. So So naturally what happens is T10 is for the umbilicus. Innervation of the umbilicus we have discussed yesterday, the T10. So referred pain of testis, ovary and even appendix. Above that 8, 9 epigastric region. So pain from the stomach region can actually referred pain over here. Same way below T10, pain arising mainly from the renal. From the kidneys can also referred pain can be felt. Okay. So that is the importance of the segmental innervation or the dermatomes. And always remember there is an overlapping of the dermatomes. They are not strictly confined themselves to that segmental area. So coming to the contents of the rectus sheath, you are able to see the contents are mainly rectus abdominis muscle and the pyramidalis muscle, the two muscles. Vessels are the superior and inferior epigastric arteries and the veins. Then of course the nerves piercing the rectus sheath, the lower 5 intercostal nerves, and the T12 nerve is actually the subcostal nerve. These are the contents. So coming to the rectus abdominis muscle. Rectus means it is straight. It arises from two heads, medial head and a lateral head. Medial head is from the pubic symphysis and lateral head is from the pubic crust and the tubercle. It passes above within the rectus sheath and gets inserted as 4 fleshy slips, the medial one to the xiphoid process and the lateral slips to the 5th, 6th and the 7th costal cartilage. Okay. The upper part is somewhat wider as compared to the lower part. That is the insertion of the rectus abdominis muscle. 4 fleshy slips from medial to lateral. Not only that, in between you also see tendinous intersections. Mainly at 3 levels you can see, one at the level of xiphoid process, one at the level of umbilicus, and the third one is between these two, midway between the first and the third intersection. Occasionally a 4th intersection also might be present, and if that is present it will be below the level of umbilicus. Usually 3, sometimes 4 tendinous intersections are also observed. Now these tendinous intersections, what do they prove? One thing is they are segmental in development. It is not a single muscle. So segmentally it has developed and they have fused at the region of tendinous intersections. So that means they are from the different myotomes. Okay. The different myotomes, and these have fused and appear as a single muscle. Now why actually it is segmental in innervation, segmental in development, and why these tendinous intersections are present? That we will come to it while we discuss about the actions of these muscles. Then, like other muscles, it increases the intra-abdominal pressure, compresses, and it is also a flexor of the vertebral column. It is a flexor of the vertebral column. So lower 6 thoracic intercostal nerves, they supply. The next muscle, not much important, is the pyramidalis muscle. So you are able to see a very short muscle from the pubic symphysis getting inserted into the linea alba. Okay. At the level of the arcuate line. Sometimes it might be absent totally on both sides, or sometimes it might be absent on one side. The nerve supply is by the subcostal nerve, T12 nerve, and it is considered as a tensor of linea alba. So why it tenses the linea alba? That part of the action is not clear. So then what happens if the pyramidalis is absent? In some persons the pyramidalis is absent, then naturally how the tensa alba, linea alba is tensed. So the action of the pyramidalis muscle is obscured. So two muscles which are present there, then we have two arteries inside the rectus sheath. They actually enter via the posterior wall of the rectus sheath and then they anastomosis within the muscle. The two vessels are there. Superior and inferior epigastric arteries. Superior epigastric artery is a branch of internal thoracic artery. The internal thoracic artery again divides into two terminal branches. One is the superior epigastric and other one is the musculophrenic artery. So this superior epigastric artery passes by piercing the diaphragm within the muscle fibers, the sternal fibers and the costal fibers, between the opening between these two, the superior epigastric artery. What happens? It will pass through this opening in the diaphragm, then it will enter the posterior wall of the rectus sheath and then anastomosis with the inferior epigastric artery. It is a branch of external iliac artery just given above the inguinal region or just above the inguinal ligament. So enters by piercing the posterior wall, that is the rectus sheath, in front of the arcuate line. This I have already told while I am discussing the arcuate line. And what happens? It anastomosis with the superior epigastric artery. And this anastomosis mostly takes place at the level of umbilicus. Inferior epigastric artery is actually a branch of the external iliac artery. Now some of the branches of the inferior epigastric artery. So here you are able to see just above the inguinal ligament, it is giving the inferior epigastric artery. Mainly it gives cremastric branch which will enter the spermatic cord and mainly supplies the structures of the spermatic cord. Contains three arteries in the spermatic cord you have. One is actually the testicular artery, other one is the artery to vas deferens, and this is actually the cremastric artery. Then pubic branch, it will be seen mainly along the femoral sheath, most medial to the femoral ring, the pubic branch. Sometimes what happens, this pubic branch will be enlarged. If the pubic branch of the obturator artery is not contributing or it is very much reduced, then what happens is this pubic branch will get enlarged and it is actually called as the abnormal obturator artery. So this should be taken care while you are reducing the femoral hernia and incising the inguinal ligament. It will be related very intimately to the inguinal lacunar ligament. Mainly the expansion of the inguinal ligament is the lacunar ligament. So incise the lacunar ligament if you are going to actually repair a strangulated hernia. You have to push back the contents. At that time, you should take care whether if this pubic branch is enlarged and present as abnormal obturator artery. You should secure this branch so that you don't actually rupture this artery. So cremastric branch, pubic branch, then you have other muscular branches, peritoneal branches and anastomotic branches of the inferior epigastric artery. Not only that, if you look at the inferior epigastric artery, to the inferior epigastric artery. Now this inferior epigastric artery, you see it actually enters the posterior wall of the rectus sheath. Before it is entering the rectus sheath, it is present immediately medial to the deep inguinal ring. It is actually present medial to the deep inguinal ring. So it serves as a very important structure or landmark to identify the deep inguinal ring for the surgeon. And not only that, in case of inguinal hernia, if you look at the deep inguinal ring located, and if the hernial sac is lateral to this inferior epigastric artery, then actually it is an indirect hernia, and if it is lying medial to the inferior epigastric artery, it is actually a direct inguinal hernia. So now coming to the functions of the rectus sheath. So you all know that rectus sheath invests the rectus abdominis muscle. Now first of all, the rectus abdominis muscle itself is very straight in the midline. On either side you have vertically oriented muscle. It itself to some extent gives protection to the anterior abdominal wall. The same muscle in the thorax, it is not that much developed. You can call it as the your transversus thoracis muscle, or sometimes you have a retrosternalis muscle. But here it is very much developed. Here it actually provides some protection because these three muscles through their aponeurosis are getting inserted into the linea alba. So near to their insertion, this rectus abdominis muscle is present. So like a strip or belt. Then this muscle again is itself covered by the rectus sheath, which is protection to the muscle itself. So it actually prevents injury to the anterior abdominal wall, the rectus sheath, in the region of the rectus abdominis muscle. So it adds strength to the abdominal wall, as I told you, because like a thick belt, it is protecting this area in the median and the paramedian region, because it is here all the aponeurosis tends to get inserted, so they don't get split near to their insertion. Then it increases, the rectus sheath increases the efficacy of the rectus abdominis muscle. Wow. So when you flex or bend, naturally it should not bowstring. This I have discussed in the initial slides itself. And not only that, when the anterior abdominal wall is going to bulge or distend, okay, when the stomach is full, or in case of your pregnancy with the uterus in women, when the uterus is going to abnormally expand, the rectus abdominis muscle should not go wide apart or split. So that is again actually prevented by this rectus sheath. Now, the whole of the anterior abdominal wall can be divided into above the umbilicus, an upper part which is actually called as the bursting part, and the lower part which is your bulging part. Now if you look here, the upper part which is immediately below the diaphragm. Below the diaphragm, so due to the piston movements of the diaphragm, when you inspire, the diaphragm is displaced downwards. So all the abdominal contents, they naturally bulge to the front. Okay, so that is why the anterior abdominal wall is actually firm but elastic and allows distension, and there is no deep fascia. The upper part is under tremendous pressure because of the movement of the diaphragm, and it is called as the bursting part. So what is preventing to some extent is the rectus abdominis muscle. That is why the rectus abdominis is in the form of tendinous intersection. Three places the tendinous intersection you see. It gives strength to the muscle because there is no bony attachment for the muscle anywhere here. So if you put any bones in between here, then again what happens? The wall cannot distend or expand. So it prevents the restriction. So because of that no bony attachment, the rectus abdominis as tendinous intersections, thereby the muscle is not split during any stretching of the anterior abdominal wall. And you know, 3 tendinous intersections are there, and 4th one, if at all, it might be present below the umbilicus. So these tendinous intersections mainly protect the rectus abdominis from being split, especially the upper part of the abdomen, anterior abdominal wall, the bursting part. Now when the upper part is under pressure due to the diaphragmatic movements, when you come to the lower part, so here the lower part you have the coils of intestine, then you have your colon and all those structures. Due to the erect posture, gravity, everything, and all these organs, they tend to come below. Okay, so weight bearing increases below, and they again tend to bulge anteriorly, because anteriorly only the abdominal wall is distensible. Posteriorly you have your pelvis and the lower part of the lumbar vertebra. It cannot bulge behind. Okay, and because the muscles are very stiff and massive behind, because they have to maintain the erect posture, so that is why the abdomen wall is built to allow expansion. Okay. Now, so because of this pressure of erect posture and the weight of the coils of intestines, what happens is, again the rectus abdominis is under undue pressure to get split apart. So again, to prevent this only, the anterior wall of the rectus sheath is thicker and reinforced by all the aponeurosis of the anterior abdominal wall muscles. So that is why below the arcuate line the anterior wall is thick. Okay, all the layers of the rectus sheath pass anteriorly, and posteriorly you have only the fascia transversalis. Now you might ask, why sir, why actually in the posterior wall itself these aponeurosis could have been present and strengthened? If at all we strengthen this area, then what happens is, it will restrict the bulging of these part here itself. So again the purpose will not be achieved. So that is why, to allow bulging as well as to give firmness and protection, the anterior wall is strengthened. The anterior wall of the rectus sheath in the lower part is actually strengthened. If this wall is thicker here, then it will restrict the movements of the coils of intestine or bulging to some extent. Okay, so these two aspects are to be borne in mind, and that is why it serves as a natural belt, lower part, the anterior thick wall, from preventing the abnormal bulging. Coming to the applied aspects, with respect to the applied anatomy, divarication or diastasis of recti. Divarication or diastasis of the recti occurs. Now, how actually this occurs? Abnormal stretching of the linea alba, and thereby the two rectus abdominis muscles are wide apart. So naturally it becomes weak. The anterior abdominal wall is weak. In children, to some extent it occurs because the linea alba and the connective tissue part is not completely developed. It might occur in multiparous women, multiple pregnancies. In those cases it might happen. When the gap is more than 2.5 centimeters between the two rectus abdominis muscle, then actually it is divarication or diastasis of the recti. Okay, separation of the rectus abdominis muscle. This muscle becomes prominent or bulged, especially when the muscle is contracted during some exercises, weightlifting or strenuous exercises. So you can examine the divarication of recti by asking the patient to lie on his back, then flex his knee 90 degrees, and then you lift the chin, lift the head of the patient so that the chin touches the sternum. Then you can see the muscle contracting and you can see the muscle will bulge. Now, We also have to rule out whether this bulge is only because of divarication of recti or not because of any hernias, because hernias are also common, epigastric region, umbilical region. Okay, so that means only you can see it becomes prominent while during contraction, then and if it is present on to the side of the midline, then you can actually diagnose to some extent it is because of the divarication of the recti. So treatment is strengthening the core muscles, or in extreme cases they go even for the surgery. So that is all about the rectus sheath. Thank you for your patient listening.